From the JAMA Network, this is JAMA Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Surgery.
Welcome, JAMA Surgery listeners. This is Amalia Cochran, the Web and Social Media Editor for JAMA Surgery. And today I am here discussing pregnancy and parenthood among U.S. surgical residents with Dr. Janczewski at Northwestern University.
Thanks for the opportunity. I'm excited to be here.
And Dr. Erika Rangel at Massachusetts General Hospital and Harvard Medical School.
Thanks so much for having me. We're really excited to talk about this paper with you guys.
I'm going to start out acknowledging that both this work and previous work from your group has used partners of male surgical residents with pregnancy as a comparator for the female surgical residents with a pregnancy. One of the questions that I have never had the opportunity to ask you in person, Dr. Rangel, is why did you think this comparison was important for your work? And do you see any potential pitfalls of using that group for comparison?
So the advantages of asking the male residents about their partners are several-fold. So first is that the partners are more likely to be comparable in age with the female surgical residents compared to other groups of high socioeconomic status or other professional women. And age is a major risk factor for obstetric complications. Second is that there is relative socioeconomic homogeneity among physicians, especially because male surgical residents have the same job, the same pay, the same medical benefits as female surgical residents, and therefore they're more likely to have very similar social determinants of health with regards to pregnancy. For example, they have the same access to care. And third, we know from data that physician trainees have a better than average recall of medical events. And they actually have even better memory retrieval of emotional events, especially negative events. So we found that male surgical residents were able to recall a lot of the obstetric events in their partners with reasonable accuracy. We actually looked at using some alternative options, and we ended up feeling like there was really no other group that was really more similar. So even if we had chosen female residents in non-procedural fields, for example, just by virtue of the fact that they had self-selected out of surgery made them probably different from female surgical residents in really important ways that will end up impacting their obstetric risk. For example, if we did a study that compared pregnant medical residents who worked 80 hours a week, and we compared them against pregnant surgical residents who worked 80 hours a week, we would probably isolate prolonged standing and perhaps mistreatment as the main risk factors. And the problem with doing that kind of a comparison is that you end up obscuring risk factors that brought these types of groups into surgical residency. For example, we find that surgeons tend to score very highly on conscientiousness and likely to reduce the chance of them asking for work reductions. And in addition, because our training is very long, much longer than other specialties, surgical residents end up being older than other trainees and other specialties. And again, age is a big risk factor for obstetric complications.
I think the other thing that I'll just add that I think is worth noting is that the partners of male residents are certainly not a true control group for obstetric complications, but we use this comparison to show that there's disparities that exist in the experience of starting a family between men and women in surgery. And because obstetric complications have the potential for long-term health implications for both the mother and the child, that this also may profoundly impact the physician workforce, particularly among female surgeons moving forward.
I want to talk a little bit about Table 2 because it is absolutely rich with data, and I really struggled with where to start in terms of talking about it. And so I wanted to ask what your investigator group considered the most interesting finding from Table 2.
It has a lot of rich data, but also kind of hard to wade through. And similar to prior studies we've done, we found that female residents in this study had a much higher odds of having pregnancy complications compared to partners of their male co-residents. But because this was such a large sample that included really the majority of U.S. surgical residents, it nicely corroborated those findings of high obstetric risks that we saw in other national samples, but which were criticized for narrow or maybe biased samples. I think even more interesting to me is that once we controlled for mistreatment, those adverse obstetric outcomes didn't have an impact on burnout and thoughts of attrition. So the reason that's significant is that it suggests it might actually be the behavior and the work environment surrounding the pregnancy experience rather than the physical strain of being pregnant that drives a lot of the challenges surrounding pregnancy and parenthood in our profession. And it also tells me that making policies just to protect maternal fetal health during pregnancy aren't going to be enough to reduce burnout and reduce thoughts of attrition. There has to be a lot of work done surrounding our culture.
One of the other things that really stood out to me, besides the mistreatment data, was the difference in the advice about having children during training. I've certainly heard all sorts of variants around what's the right answer, and I suspect both of you have as well. I wanted to get your thoughts about the impact of the fact that we are giving different messaging to our residents that is gendered messaging about childbearing during training.
I agree. I think the impact is definitely significant. And while the magnitude of mistreatment among resident parents is probably not all that surprising, I think it shows how much work we still have to do in our specialty with regards to culture, just like Dr. Rangel was just saying. Some of the behaviors that we captured in this study are definitely more overt, such as experiencing discrimination based on being pregnant or having a child to care for. But some of the other ones that we captured, although perhaps well-intentioned, send the message that our profession is not compatible with raising a family, especially for women. For example, in our study, we found that about 25% of female residents are told that they should not have a child during training, compared to only 3% of male residents, as you pointed out. And 40% of female residents are told that they should go into an easier specialty because they're a parent. Anecdotally, I'll just share that we actually held a cultural complications conference at my institution based on this very topic, where one of the cases discussed was a female resident being counseled to pursue an easier specialty because she had children. And although it was anonymous at the time, it was actually my own personal experience. And I think the discussion was actually really interesting because it's true that these types of comments likely come from a good place and are a less obvious form of discrimination, but I think they may have the opposite effect of what was intended in terms of career satisfaction by telling someone to pursue a specialty they don't feel passionately about based solely on their parental status. While mistreatment is certainly much more common among female resident parents, we still found that 30% of male resident parents face some form of parental-based mistreatment as well, which is also a significant proportion.
I also wanted to ask about the use of work schedule adjustments for pregnancy accommodations, because the numbers on that were really quite similar between the female and the male respondents. And I couldn't help but wonder if we are potentially underutilizing adjustments in work schedules during pregnancy for our female residents in particular, since we know that overnight call and long days in the OR definitely have an effect on obstetric complications.
So in this study, when you look at the data, we're seeing about 20 or 25% of residents get schedule adjustments before delivery, and then 40 or 45% are getting adjustments when they first come back from parental leave. And it's really striking here that male and female residents had their schedules adjusted with similar frequency. And actually, when they first come back from work, male residents are getting even a little bit more adjustments than female residents. So I think there's a lot of room to improve support here. And the other thing is that the data in this paper show it's important to do that because low support has these consequences on burnout and attrition. I think what we need here are program level interventions that are going beyond compliance with just what's mandated by the ACGME or the American Board of Surgery. Those to me are sort of the bare minimum. For example, at our institution, we establish policies for pregnant residents where we don't ask them to take overnight call or 24-hour call after 30 weeks of gestation. And I think you really need policies like that when you're in a hierarchical culture like ours, because residents, especially the junior ones, don't feel like they have a lot of social capital and they're very reluctant to ask for accommodations. But I think it's also important to be realistic here. It's oversimplifying to say that we can just put a policy in place and things are going to change. In reality, there's a lot of practical challenges in implementing something like this. And unfortunately, most of our residency programs are structured as kind of a zero-sum system. So any leeway for one resident inherently ends up coming at some sort of a cost to another resident or the system as a whole. And so a lot of thought really has to go into creating some sort of workforce redundancy. Otherwise, there's these unintended consequences like increased burden on our co-residents. And it's tough because procedural specialties, we tend to have fewer trainees, so there's a lot of logistical challenges in creating that type of redundancy. In addition to tackling those workforce challenges, our culture really stands in the way of residents actually accepting what's offered to them in terms of needed schedule adjustments. So, a core part of all of our identities as surgeons is toughness and this concept that you're going to selflessly dedicate yourself to your clinical duties, to your patients, and being willing to do whatever it takes to get the work done. So, any policy that reduces clinical work feels misaligned with those professional norms. The other thing is when we start seeing that almost 60% of female resident mothers are experiencing some sort of pregnancy and parenthood related mistreatment, it's not really surprising that women are reluctant to change their schedule because they're worried about this so-called motherhood penalty. They're worried about threatening their reputation or maybe limiting their future professional opportunities. So they'll push themselves beyond what the policy asks them to do. And I think it's really important to have senior advocacy at a lot of levels to break that taboo against taking time off. I don't think you can underestimate the importance of getting support from the senior residents. They end up being the direct mentors. They're often the schedulers for the more junior residents. So they end up having a lot of influence on how expectant residents feel like they're perceived by the entire group. And there's a lot of soft ways for them to say no if they don't buy into the policies. So if these types of schedule adjustments are not well accepted, expectant residents really aren't going to challenge the hierarchy. They're not going to bypass their senior residents and try to get approval from the residency leadership. So it's about starting with your residency class and making sure that everybody understands why we're doing this and how we're going to make it fair and how we're going to make it advantageous for everybody.
Something that I was fascinated by regarding your respondent pool was what I considered to be a shockingly low number of LGBTQIA or LGB plus, as you put it in the paper, respondents. Do you think that there may have been some response bias within this group that limited them responding to the survey?
For some context, looking at the 2019 ABSITE survey data that was also collected through the second trial with a similarly high response rate, they found that less than 5% of surgery residents identified as LGBTQIA, whereas in our current sample, about 2.5% of the resident parents identified as LGBTQIA. And so while there likely is some form of response bias present, I think the actual number of LGBTQIA respondents experiencing a pregnancy may be fairly accurate given other data, which estimates that about 30% of individuals who identify as a part of this community will raise children. But I do think that adoption and surrogacy remain really understudied and something that we didn't capture in our study as well, which represent the journey to parenthood for a significant group of this population. And historically, we know that adoptive parents and those who have a child via surrogacy receive less leave, less paid leave, and even less workplace benefits overall. And additionally, as identified in one of Dr. Rangel's prior studies, the use of assisted reproductive technologies, adoption, and surrogacy will often cost more than $40,000, which for context, in most residency programs, that's more than half of a resident's annual salary. And so I think it's going to be extremely important to evaluate how LGBTQIA residents and intersectional identities influence parenthood experiences moving forward.
For listeners' benefit, the ABSITE is the American Board of Surgery and Training exam. So one of the questions that clearly stands out in this day and age is the fact that you all identified the study participants as male or female in terms of their responses. And I was curious if there was consideration given to how to manage transgender surgeons as part of this.
That's another great question and something that we really thought carefully about as well. Like you mentioned, there was a really low proportion of residents within the cohort who identified as LGBTQIA. And when we took a deeper dive within that specific cohort, we actually found that there was no one within it who identified as transgender, who had experienced a pregnancy during their clinical years of training, which I think goes back to our previous points that pursuing pregnancy and parenthood within that community can be even more challenging and something that warrants future study, as the road to parenthood is often more challenging and costly as well.
I have a couple of my mentees who are new program directors this year. They've been associate or assistant program directors, and they are moving into program director roles. And so, based upon your findings, if you could give one piece of guidance regarding pregnancy and parenthood to a program director for a surgical training program, what would that advice be?
I think it's so important to set the tone in your program that having a child during surgical training is both an expected and celebratory event. I consider myself really fortunate and lucky to be at a program that has been nothing but overwhelmingly supportive of my own pregnancies. But being involved in this work, I quickly realized that that is not the majority of cases across the country. And so one of the strengths of our profession is without question the team dynamic, where many of us consider the people we trained with to be extensions of our own family. But fostering that means we send the message to expectant trainees that they're expanding the family and not burdening it, where the first word when any resident tells you they're expecting should be congratulations, even if behind the scenes you may be thinking, how am I going to provide coverage for this person?
In this case, I really think having an ounce of prevention is worth a pound of cure. It's just a fact that, just as we were saying, it's becoming more and more common for residents to have children during training. So thinking ahead by putting those parental support policies in place and building up your workforce redundancy, talking to your residents and reassuring them that you have a plan in place for fair coverage, I think that goes a long way in mitigating anxiety about a previously taboo topic. And similarly, you can emphasize that building that redundancy is something that you put in place to support all residents in all life events, regardless if they plan to start a family or not. 5 to 8 years is a long time to be in training, so it goes a really long way to show your residents you're invested in both their personal and professional success. And really, I always repeat myself that it's a relatively short expenditure with long-term returns on investment to support people in this critical life milestone.
Dr. Janczewski and Dr. Rangel, thank you both so much for taking time to talk with me today and so that we could all learn more about your work.
Thanks for having us.
Thanks so much for the opportunity.
This episode was produced by Shelley Steffens at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.